Good morning, good afternoon, and good evening to our webinar participants. My name is Thomas Krüger, and I'm the product manager of the Babylogs VN500, 600, and 800 at the Dräger headquarters in Germany. I would like to welcome you to our international webinar conducted by Professor Dr. Martin Keszler. Dr. Keszler is Professor of Pediatrics at Brown University, Women and Infant Hospital of Rhode Island, Providence, USA, where he's the Associate Director of NICU and the Director of Respiratory Care Services. Martin has published numerous original papers, review articles, book chapters, and editorials, presented over 300 lectures at national and international conferences, moderated or conducted over 50 workshops or roundtable discussions, and was a visiting professor in over 20 medical institutions in the US and abroad. Professor Keszler has a very strong interest in neonatal ventilation and is an internationally recognized expert on high-frequency ventilation, ECMO, and volume-targeted ventilation. Professor Keszler is in great demand as a speaker all around the world. He is very experienced and passionate teacher, and we are very happy that we have him here today for this webinar. Now I would like to hand over to Dr. Keszler for his presentation.
Well, thank you very much, Thomas, and welcome to the seminar. It is early morning here, but I know it's evening where most of you are. So I'm excited to be here to have an opportunity to share with you some insights about volume-targeted ventilation and how to best implement that. So we'll talk about the rationale for using it, the evidence of its benefits, and talk about how it works. We'll mention the importance of distributing that tidal volume evenly into an open lung and talk about some specific guidelines. So, of course, the reason we all try to use the best possible approach to mechanical ventilation is to try to prevent lung injury, bronchopulmonary dysplasia. And while ventilation is important, I want to make the point with this complicated slide that there are many other factors that influence the eventual pulmonary outcome. So, of course, fetal lung development can already be adversely affected by things like chorioamnionitis, oligohydramnios. Events around the time of delivery are critical, and this is a different lecture to talk about delivery room management and resuscitation, but that can greatly influence eventual outcome. And then there are all the factors above the line here in orange that we know have an impact on postnatal growth and development, and there's some things we can do to improve. But the point here is that development of BPD is very multifactorial, and that we need to do everything correctly in order to optimize outcome. Mechanical ventilation certainly is an important one, and that will be the focus of today's lecture. So, of course, we're increasingly using non-invasive respiratory support because that's the best way of avoiding ventilator-associated lung injury. But many of our most immature infants, in fact, of course, do require mechanical ventilation. And so we'll talk about how to do that with the minimum of adverse consequences. So we'll start by talking about why volume-targeted ventilation, volume guarantee is the way to go. I'll show you some evidence that volume trauma rather than barotrauma is what we should be worried about. I think you all have the experience that it's very easy to inadvertently overventilate an infant. And we know that hypocapnia is bad for the brain and it's bad for the lungs. And we'll talk about the distinction between volume-controlled ventilation and volume-targeted ventilation, as in volume guarantee. So these data have been around for many years and largely ignored, but what this shows is an experiment using small animals that were exposed to progressively higher inflation pressures. And in one group in the open bars, the lungs were free to expand. And in the group with the closed bars, there was a tight plaster cast around the chest and abdomen, restricting chest wall excursion and therefore limiting tidal volume to a normal value. And They looked at capillary infiltration coefficient as a measure of acute lung injury. And what they showed was that at 15 centimeters of inflation pressure, there wasn't any impact on acute lung injury. It's essentially, acute edema. At 30 centimeters, though, there was already evidence of acute lung injury after even a short period of ventilation, but no change where the lungs were constrained from reaching excessive volume. It's not surprising that in these animals with normal lung compliance, inflation pressure of 45 centimeters resulted in a very large increase in lung edema. What is surprising is that despite exposure to the same high pressure, there was no change where lung volume was constrained, indicating that pressure exerts its injurious effects largely through excessive tissue stretch over expansion, and that if that pressure does not result in a correspondingly large degree of inflation or large tidal volume, lung injury may not occur. Similar experiment using small animals again demonstrated that whether the excessively large tidal volume was generated with high positive inflation pressure in red. Oops, my mouse advances inadvertently. Excessive large tidal volume positive pressure in red, or negative extrathoracic pressure in yellow, there was again evidence of a great deal of acute lung injury measured again as lung water and protein leak. Whereas same high inflation pressure, but again chest wall restriction with a tight elastic bandage resulted in much less lung injury. So pressure was removed from the equation with the negative extrathoracic pressure, suggesting that it is indeed excessive tissue stretch, not pressure, that results in acute lung injury. So we have had a number of studies, a number of meta-analyses that have compared pressure-controlled to volume-targeted ventilation. The most recent one, 2017, that shows clear benefits to volume-targeted ventilation. The combined outcome did not quite reach statistical significance because the confidence intervals crossed 1, but the point estimate suggested a significant reduction in this combined outcome of death of BPD. All the subsequent ones, however, are significant. BPD by the traditional definition was reduced by 27%. With confidence intervals shown here, and a number needed to treat, a benefit of only 8, which is a remarkably low number. Severe intraventricular hemorrhage was reduced by half, so was the combined outcome of periventricular leukomalacia or severe intraventricular hemorrhage. Again, confidence intervals don't cross 1, so it's a significant difference. A number needed to treat shown here. Pneumothorax was reduced by half. Hypocapnia was reduced by half. And the duration of mechanical ventilation was reduced also by more than a day. So these are pretty dramatic benefits, and one would therefore expect that we should all be using volume-targeted ventilation. Sadly, that's not quite the case, although in many parts of the world it has occurred. In the United States, where I work, it's still not as widely embraced as available evidence would suggest that it should be. All right, so let's talk a little bit about the basic physiology and basically how volume versus pressure control as a primary variable works. So if we look at volume as the primary control variable, and this is typically how adults and pediatric patients are ventilated. Volume is the independent variable. Volume is what you set. And this is a classic pressure volume loop, pressure on the horizontal axis, volume here. And so what happens when compliance increases? So here's the loop with the lungs that are quite stiff, so relatively low tidal volume and a lot of pressure. When compliance increases, it'll simply take less pressure to deliver that same tidal volume, because volume is what is fixed. Okay, so pressure goes down, tidal volume stays the same. In contrast, when pressure is the primary control variable, again, here's our pressure volume loop, pressure, volume. When compliance increases, the pressure now is fixed here. So what will happen, of course, is that volume goes up. Now, that may be a good thing if the lungs were stiff and tidal volume was inadequate, but if we selected an inflation pressure that was appropriate to deliver a normal tidal volume and then compliance improves, we could now have excessively large tidal volume with lung injury and hyperventilation. So this is, of course, potentially dangerous. So why don't we all use the traditional volume controlled ventilation that is used in the adult world? And the problem here is that what volume controlled ventilation of the traditional sort controls is the tidal volume that is delivered into the proximal end of the ventilator circuit over here. And of course, there is going to always be some loss of volume to compression within the circuit and humidifier, and there's going to be some stretching of the elastic circuit. That's not a problem if you have a large patient. It's not a problem when you have lungs that are many times larger than the circuit. But in a tiny premature baby, where the lungs are actually smaller than the compressible volume of the circuit and humidifier, much of that tidal volume delivered here will be dissipated within the circuit. And on top of that, we have the issue of uncuffed endotracheal tubes with a variable leak around that endotracheal tube, leading to additional and variable loss of volume. So while we tried this back in the 1980s, when I was starting my work, it turned out not to be very practical. And therefore, we all reverted to what we now use, which is pressure controlled or pressure limited ventilation, which in its basic functionality is nothing more than a mechanical T-piece resuscitator, like a neopuff, where during the expiratory phase, you have continuous flow of gas in the circuit. The expiratory valve here is open. There's a PEEP valve maintaining distending pressure. The patient can breathe in and out of the circuit. And when the ventilator cycles on, the expiratory valve closes and the circuit's pressurized. And as pressure rises, gas flows into the patient's lungs. And the volume delivered is proportional to the pressure within the circuit and the compliance of the lungs. So pretty straightforward. And we don't worry about a leak around the endotracheal tube because there's plenty of fresh gas available to maintain pressure within the circuit. And it was the ease with which we could ventilate in the face of large leak around the endotracheal tubes, and the conviction that pressure is the most important factor in lung injury. I refer to that as barophobia. But it turns out that volume is what we should fear more than pressure, as I hopefully convinced you. So I want to make a distinction between volume controlled ventilation that I just described a moment ago and volume targeted ventilation, which in fact is pressure controlled ventilation with volume targeting. And let me explain. So there's a difference in the flow waveform and how gas is delivered. So with pressure controlled ventilation, the ventilator delivers a certain pressure. As I said, the circuit's pressurized and gas flows into the baby's lungs, again in proportion to compliance and pressure. In contrast, with volume controlled ventilation, there is a continuous flow of gas into the circuit and pressure rises passively, reaching peak just before exhalation. Okay, and here the problem again is the loss of volume to compression. So the waveform is different, and the ability to compensate for leaks is different. So volume targeted ventilation, volume guarantee, is pressure control with volume targeting. Many authors refer to all forms of ventilation that attempt to control tidal volume in some fashion as volume targeted. But I think that causes confusion, and I think we need to keep them distinct, because what volume guarantee and related modalities on some other devices are really pressure controlled ventilation with volume targeting, different flow pattern. And the control algorithm is basically become similar in different devices, although they're not all the same. And I will talk about some of the specific advantages of the Dräger device. But in principle, they all begin with some form of pressure delivery. The tidal volume is measured. It's compared to the target. And depending on whether the measured tidal volume is less than target, equal to the target, or above the target, the inflation pressure for subsequent ventilator cycle is increased, kept the same, or actually decreased. And so that's a fairly straightforward algorithm. It does not make large adjustments from one inflation to the next, but it gets the job done very nicely, and there's been lots of evidence for that. I want to draw the contrast between volume targeted ventilation, volume guarantee, and other approaches to some sort of interactive support that's out there. And specifically, I'm talking about something available on certain devices called NAVA, neurally adjusted ventilatory assist, or proportional assist ventilation. Those devices are out there, and they take a very different approach. So if we look at the effort generated by the baby, the inspiratory effort measured here by the electrical activity of the diaphragm, when baby generates very low amount of effort, the ventilator generates limited support. These are positive feedback mechanisms. So the pressure generated by the device is proportional to the effort of the patient. It assumes mature respiratory control. When the patient generates more effort, more pressure is delivered. There is an obvious difference here with volume targeting. It's a negative feedback. So when the baby does not generate adequate effort, the ventilator increases pressure to try to maintain a stable tidal volume. When the baby generates a large inspiratory effort here, the ventilator drops the pressure to avoid excessively large tidal volume. So the goal here is to maintain stable tidal volume. The goal here is to assume that the patient knows what they're doing, but just can't do it. Well, our preterm infants don't have mature respiratory control. They tend to have this periodic breathing. And when you apply positive feedback to this sort of breathing pattern, you're going to exaggerate these differences and have even larger fluctuations. And you can see this here from a publication using NAVA. And the authors are very proud of how closely the ventilator pressures track the electrical activity of the diaphragm or the patient's inspiratory effort. But to me, this is potentially dangerous. So here the baby at the beginning is hypoventilating, generating inadequate respiratory effort, and the ventilator is generating a very low level of support. Here the baby is breathing much more actively, more pressure is generated. Here, again, not much effort, a brief pause, and that's tracked by the ventilator. So you can see then perhaps the baby was disturbed, touched, and there's a very high inspiratory effort. And in response, the ventilator generates a very high peak inflation pressure. And so you can appreciate that there is very dramatic fluctuation in ventilator-generated pressures that likely result in some excessively large tidal volumes and significant fluctuations in PCO2. So to me, while this technique is very attractive for certain kinds of patients, and it may be a good idea for non-invasive support, in small preemies, it's potentially dangerous. And I think the approach of negative feedback, recognizing the functional immaturity of the preterm infant, which was specifically developed for management of preterm infants. Volume guarantee is what I'm talking about, is in fact a much more sound approach and a much safer approach. But these things are out there, so I wanted to bring your attention to some of the potential downsides, and they really haven't been those other techniques have not been adequately studied. All right, so before we launch into how to use volume targeted ventilation, I'll just briefly remind you again of the now documented benefits of volume guarantee. So we and others have shown that it does maintain a relatively constant tidal volume. It is not completely constant because the baby's contribution, the baby's respiratory effort does fluctuate. And as any servo control, it is always seeking the target, but it will not be a monotonous, stable tidal volume. Some degree of variation of tidal volume is actually desirable. Totally monotonous ventilation leads to atelectasis. So this is clearly a benefit. It avoids those large changes in tidal volume and compliance improves, as it does when we give surfactant and when we help the baby recruit tidal volume by using adequate and expiratory pressure and such. So very important. And again, by doing that, we're avoiding this overdistension, the volume trauma that we've talked about, and the most importantly, perhaps the hypocapnia. We know that compliance can improve very rapidly with surfactant. We know that moving the lungs from relatively allectatic state to optimal lung inflation dramatically improves lung compliance. All of these things are good, but unless you can stand there and monitor tidal volume and manually adjust inflation pressure, you're going to get into some problems. The other benefit is automatic lowering of pressure during weaning. The ventilator in volume guarantee mode does not wait for the next blood gas. It does not wait for morning rounds to make a decision. It weans in real time, and therefore it leads to more rapid weaning from mechanical ventilation, and that I showed you has been demonstrated by a significant margin. And finally, it compensates for that highly variable respiratory drive, which we talked about. So I want to briefly also talk about the importance of making sure that that nicely controlled tidal volume is evenly distributed into an open or properly recruited lung. What do I mean by that? We think of RDS as a homogeneous disease, and a plain chest radiograph suggests that it is, but if in fact you do a CT scan or an MRI, you will see that there are gravity-dependent differences, and that also the atelectasis is posterior, and there is aerated lung anteriorly. You can nowadays see this very clearly with electrical impedance tomography in real time, which is becoming more available of late. And it's turning out that it is impossible to have a completely homogeneous lung, but we know these gravity-dependent differences exist. And if we ventilate a lung that has a lot of atelectasis, and this is schematically shown here, there's several sorts of lung injury that are going on. We refer to this collectively as atelect trauma. We know there's increased surfactant turnover in the alectatic portion of the lung. There are shear forces at the boundary here. There are areas of the lung that are inflating and deflating, which is also quite injurious. But perhaps the worst part is that because of Laplace's law, which tells us that the pressure needed to distend an alveolus or a spherical structure is inversely proportional to the radius, we know that it takes higher pressure to open the alectatic alveoli than it takes to overexpand the alveoli that are already open. And the practical consequences consequence of this is that majority of tidal volume delivered into these lungs will enter these already aerated alveoli, leading to regional volutrauma, while the rest of the lung remains alectatic. And this has actually been documented in experimental studies now a number of years ago, where they've demonstrated that when you apply relatively large tidal volumes, so we'll focus on the solid bars here, there was a lot more injury measured here by histologic score in the non-dependent regions, that is the anterior apical, already inflated portion of the lung. Similar looking composite lung injury score, histologic. Also looking at a variety of markers of lung injury, cytokines, for example. Again, the non-dependent regions of the lung showed the greatest degree of injury. So this regional volutrauma in the non-dependent regions is a real thing. So it's important not only to regulate tidal volume to a normal physiologic value, but to make sure that the lung is properly inflated and that the tidal volume is distributed evenly. And so some sort of an alveolar recruiting maneuver is needed. This is sort of schematically demonstrated here, moving from left to right. And as we, and this is done basically by increasing mean airway pressure in some fashion with conventional ventilation, typically by increasing PEEP and expiratory pressure, moving the lungs from this relatively allostatic state, increasing inflation pressure, to where the lung is eventually fully open. But then once we get to that point, once the alveoli are open, they become more compliant. And therefore, we need to then decrease the descending pressure and find the sweet spot just above the closing pressure. So transient overexpansion occurs. We can see this in electrical impedance tomography. And we eventually want to reach a lower descending pressure and a nicely inflated lung. So we don't want to stay here. We used to do this. This was a mistake. It caused hemodynamic impairment. We want to slide it down to this area with an evenly expanded lung. So one of our questions, one of the puzzles that I had for a long time was why isn't everybody using volume targeted ventilation in the United States? So we did a survey and we learned some interesting things, and I'll share a little bit of information from that. But mostly just this spurred me to look more deeply into reasons and to write a review paper to try to get folks to understand. So the barriers what we discovered in that survey was mostly inertia. I wear this button to indicate that change is needed, but inertia is the most powerful force in the universe, and it's hard to change, and it's hard to learn new tricks. You can always rationalize, but the evidence is pretty strong, I think I showed you. In the United States, and perhaps other parts of the world as well, not everybody has suitable devices. Not everybody can afford the best technology. And in the United States, there's this preoccupation with using universal ventilators that can ventilate both adults and newborns, which doesn't actually work as well as advertised. But a lot of it came down to a lack of understanding of just how it works, why we should use it, and perhaps most importantly, the appropriate setting. So we'll spend some time talking about that. One of the reasons people talked about was concern about leak around the endotracheal tube. And it is, of course, an issue when you have a large leak around the endotracheal tube, and this is a study published a number of years ago, that looked at what happens when you have progressively larger leak, and there are other similar studies, and you can see that the inspiratory tidal volume goes way up as leak goes above roughly 40% or so. Expiratory measured tidal volume deviates less from the actual tidal volume. And this is the reason why volume-targeted ventilation uses exhaled tidal volume to regulate the pressure delivery. But this was also the basis of being able to calculate what the real tidal volume was. So tidal volume compensation is a real thing in the Dräger devices, and leak compensation has really made a huge difference because before that became available, it was a challenge to ventilate babies who had a large leak around the endotracheal tube, and you really couldn't do it safely when the leak was more than 40%. Now, things are very different. And in this graph, there's actually the calculated value. The leak compensated value is here, and you can see that this was the actual tidal volume was a little over 4 ml, about 4.5 ml, and you can see that calculated value remained extraordinarily stable all the way up and beyond 80% leak, which is quite remarkable. So just to illustrate the point here, and this slide is courtesy of Thomas Kruger, with some modifications by yours truly. So what we have here is the concept of tidal volume delivery. Inspiratory tidal volume is measured at 6 ml. But let's say there's a 33% leak. So 1/3, 2 ml, leaks out during the inspiratory phase. So only 4 ml actually reached the patient's lungs. The inspiratory tidal volume measured was 6. But then there's also some leak during the expiratory phase. It's less because the pressure that drives the leak is less during expiration. This is, of course, driven by the PEEP, the end expiratory pressure. But let's say there's a 25% leak, and therefore the exhale tidal volume that's measured is only 3 ml. Well, it's a 25% difference. So if you didn't have automated leak compensation, the ventilator would be chasing this number and increasing the pressure and potentially overventilating the patient. But with leak compensation, you can actually know that the lung tidal volume was 4 ml, and you can use that value. So here is another way of looking at things. So when you do not employ leak compensation, it is off here. You can see there is a very large leak in this example, about 2/3. And so the exhale tidal volume that's measured is 3.6 ml in this example. And so the per kilo tidal volume in this example is 2.4 ml. You can see the large leak. The tidal volume does not return to 0. You can see the leak here in the flow waveform. So the tidal volume that the ventilator displays and uses for regulation of inflation pressure is the exhale tidal volume. Okay. Now, that's a problem, right? Because this is not real. We're relying on this exhale tidal volume that is affected by this very large leak. So when you turn on leak compensation, and that's something that you have the choice of doing, but I would strongly recommend that you use it. And this is the reason. In fact, the calculated tidal volume is 6.8 ml. The calculated tidal volume per kilo is 4.6, which is, where you might want it for a typical preterm infant. 2.4 would be completely inadequate, but that's not real. 4.6 per kilo is the real tidal volume that this baby was being ventilated with. So you have two values displayed here. This is the exhale tidal volume that's measured. This is the tidal volume that's in fact calculated, and that is the correct tidal volume and a minute ventilation. Okay, so this is really awesome because we no longer have to worry about significant leak around the endotracheal tube, and up to 70% or perhaps even a bit more leakage, you can still effectively use volume targeted ventilation, which I think is a game changer. Right, so let's spend the rest of the time talking about some of the practical aspects of how we should do this, when we should do this, and what the appropriate settings are for different kinds of babies, because it turns out that one size does not fit all. And that's the most common mistake, is that people read somewhere that 5 per kilo is the right tidal volume. And in fact, that's what the survey that we did revealed, that most people, regardless of the clinical scenario, were using tidal volume of 5 per kilo. And that's good for some babies, but not all babies. All right, so when should we start? When should we use volume guarantee? I argue that we should start it immediately upon initiation of ventilation, because that's when compliance changes most rapidly. We're giving surfactant, we're recruiting lung volume, the baby's clearing lung fluid, compliance is changing. So we now have enough data to know that we can just go ahead and start right off the bat. We can set the appropriate tidal volume, and that depends on the kind of patient that you are treating. If it's a typical preterm infant, 800 grams, 1,000 grams, first few days of life, acute phase of RDS, some sort of homogeneous lung disease, somewhere around 4 to 5 ml per kilo works well. A little bit less for the larger babies, a little bit more for the smaller babies, because it turns out that the smaller the baby, the larger the tidal volume needs to be, and I'll explain why in a moment. I'll show you the data. But for really small babies, perhaps less than 6, maybe 700 grams, 5 to 6 ml per kilo may be the right initial tidal volume. These are all averages. Babies with meconium aspiration syndrome and air trapping, or older babies with chronic lung disease, need a larger tidal volume. Babies with severe established BPD need a much larger tidal volume. And these are, again, the exhaled tidal volumes measured at the airway opening. So please be aware that these values I'm talking about are tidal volumes measured at the airway opening. Some devices that are still in use measure tidal volume back at the ventilator, and those grossly exaggerate the actual tidal volume. So these were derived from using baby-log ventilators, measured tidal volume at the airway opening. Then we need to set the pressure limit. The device will adjust pressure up and down up to a limit that you set. That limit needs to be close enough to the actual pressure to give you an alarm if conditions have changed and the ventilator is not able to reach the tidal volume that you have asked for at the pressure limit that you selected. All right. So again, since volume is the primary control variable, the pressure needs to be able to float up and down. We know that on average, the pressure generated by the ventilator will be the same or lower than with volume with pressure controlled ventilation. Okay, but it has to be able to go up and down because the baby breathes intermittently, and sometimes the ventilator is the only thing generating tidal volume, and will need to use a bit higher pressure. Your other option is if you started on pressure controlled ventilation and you now want to change to volume guarantee, you can, and if the baby's support was appropriate and the PCO2 was where you wanted it, you can observe what the tidal volume actually is with your pressure controlled ventilation and use that tidal volume as your target, and then increase your pressure limit again by about 25% to allow the ventilator to make those adjustments up and down. Again, on average, it'll be lower, but it has to be able to go up and down. And it is important to keep in mind that the relationship between lung compliance, inflation pressure, and delivered tidal volume is the same whether you're adjusting the inflation pressure manually, as in pressure control, or if you're using volume guarantee and the ventilator is adjusting it automatically. Same pressure given the same compliance will give you the same tidal volume. The difference is you're prioritizing tidal volume as your primary control variable that you want to keep stable over pressure. And we should get over our barophobia and recognize that volume is the most important factor that leads to lung injury. Okay. Now, we've advocated using assist control or pressure support as the primary mode compared to SIMV. We showed that you get more tight tidal volume regulation, and small preemies just don't do really well with SIMV. Now, you can use SIMV with pressure support, but only the SIMV ventilator cycles will be subject to volume guarantee targeting. So modalities that support every patient breath are preferred in the scenario. And of course, you have to set the other variables on your ventilator, inspiratory time, PEEP, etc., according to the patient's underlying disease process, oxygen requirement, etc. So I'm focusing on just the pressure and volume situation here. And most importantly, you need to monitor the patient's response and adjust settings as indicated by what the baby's trying to tell you. Babies are very smart. They talk to us. We just need to know how to listen to them, because you don't want to wait for the blood gas to make your determinations. The values I'm talking about here are averages. They're what the typical baby of that sort needs. But babies are different, and your patient may need more or less tidal volume. And how we know is we evaluate the patient's response. And so what can the baby tell us? Baby can tell us a lot. If the baby stops breathing after a few minutes, that suggests that we've probably taken away their respiratory drive because we've overventilated the baby. If that happens, you probably don't want to wait for blood gas to tell you that the pH is above 7.4. You should probably reevaluate the tidal volume and maybe drop it. If the baby becomes tachypnic and is retracting, that suggests that our support is inadequate, perhaps needs bigger tidal volume. With volume guarantee, you will also see if the tidal volume is too low, that the baby is bringing down the pressure that the ventilator is generating. And this you will see, and I'll get back to that issue shortly. Baby's oxygen requirement is going up. It suggests that the descending pressure is inadequate, and we're developing some atelectasis. And my favorite, the baby's fighting the ventilator. The blood gas is bad because the baby's fighting the ventilator. Actually, it's the other way around typically. The baby is quote unquote fighting the ventilator when gas exchange is inadequate. Baby, this really air hunger, a sign of inadequate support, perhaps obstructed the tracheal tube. It's maybe up against the wall of the trachea. The baby is struggling to breathe. Giving sedation is not the answer. Optimizing the ventilator settings is the answer. And so you need to re-examine what you did. You need to look at the ventilator waveforms and make some adjustments. And in reality, when we optimize ventilator settings, babies rarely require sedation. And we know that giving narcotic analgesics actually was counterproductive. It extended the duration of mechanical ventilation. It had consequences on the GI tract and some feeding issues. So optimize the ventilator, don't sedate. All right, so what about subsequent adjustments of, we've talked about this a little bit already. So you pick your first settings, you look at the baby is trying to tell you something. But you also need to consider other factors. So we talked about if you're starting from scratch, right, specifically in the delivery room right after intubation, if it's taking more pressure than you think it should, let's say, it's taking more than 25 centimeters of pressure, you want to make sure that your endotracheal tube did not inadvertently slip into the right mainstem bronchus, and that you're not just ventilating one lung, because that would certainly take more pressure to deliver a full tidal volume into one lung. So in very tiny babies, it can happen easily, right? The endotracheal tube was good, but then maybe the chin is now down, the tube slipped in, and it's taking a lot of pressure. This is where having an alarm limit, the pressure limit, relatively close to where things should be, will alert you if something has changed. It could be that the lungs are just not adequately recruited, that you need to do some sort of alveolar recruitment maneuver to improve lung compliance. It could be that you picked a tidal volume that's maybe just too much for this particular baby, and that's why it's taking a lot of pressure, because you're exceeding the physiologic tidal volumes. So this is a consideration when you're starting up. Once you have reached some degree of stability, you might be getting a blood gas. If necessary, if you need to go up or down, typical magnitude of change somewhere between 0.3, typically more closer to 0.5 ml per kilo, depends on how far from your desired target of PCO2 you are. So relatively small increments usually are sufficient. Keep in mind that it is pH, not PCO2. That's the primary driver of respiratory control. So while most of the literature focuses on PCO2 and most clinicians focus on PCO2, please look at the pH. If the pH is 7.32, but the PCO2 is 35, do not lower the target tidal volume necessarily, because the baby is reacting to their pH. So beware of that infant with metabolic acidosis. It is the pH. And what happens often is that people only look at the PCO2, decide that it is too low, lower the target tidal volume, and now the baby is just not getting adequate support. Because babies hate to be acidotic. Permissive hypercapnia is something that doctors like, babies not so much. So we have to be careful and try to correct the base deficit in any way that we can, typically not with bicarbonate, but maybe some acetate in the TPN. So you don't want to, again, keep the pressure limit way too high, because you want that feedback mechanism where if something changes, the alarm will remind you that you need to come to the bedside and reassess the patient. And again, always pay attention to the baby, the oxygen requirement, and the working pressure. If it's very low and the baby is working hard, that means the tidal volume is too low. Even if your blood gas is okay, the baby may need a larger tidal volume to be adequately supported and not be getting exhausted. And of course, what matters is not the pressure limit. So for purposes of charting, you want to refer to the working pressure, the actual pressure that's being used. All right, so let me just show you very quickly some of the data on which the recommendations are based. So a number of years ago, we looked at a bunch of very small babies. And when the PCO2 was in a normal range, we recorded what the tidal volume was. And what this shows is the extremely low birth weight infant, around 800 grams. The tidal volumes were around 4.5, 5 ml, typically where we start them. But in the really small babies, the ones I call ridiculously low birth weight infants, around 400 grams, these were mostly growth restricted babies. They needed a bigger tidal volume. And this is a function of the dead space of the flow sensor. The baby weighs 800 grams. The dead space is 0.8 to 1 ml, depending on which flow sensor you use. And that stays the same. If the baby's lungs are half the size and the flow sensor is the same size, you need some compensation. So a little bit bigger tidal volume for that reason. We looked at babies with meconium aspiration syndrome and air trapping. And what we found, again, looking at the same thing, when CO2 was normal, what was the tidal volume, is that control babies with homogeneous lung disease needed a tidal volume a little bit less than 5 per kilo. But the meconium aspiration babies with a lot of air trapping needed a tidal volume of more than 6 ml, highly significant differences. And they were also more tachypnic, so their minute ventilation was dramatically higher, yet their PCO2 was virtually identical. What this tells us is that it is wasted ventilation, increased alveolar dead space. So the disease process matters. And so these babies need a bigger tidal volume, and if you don't give it to them, they will not be adequately supported. And then there's also the progression of tidal volume over time, again, starting with those less than 800 gram babies who remained on mechanical ventilation for an extended period of time. you can see that even though we progressively allowed some permissive hypercapnia, as they were able to compensate better, with PCO2 rising to the mid-50s, it was taking progressively larger tidal volume, on average about 6 ml per kilo, but a larger standard deviation telling us that some needed quite a bit more. So, you know, we say 6 ml per kilo, but that's average. Some babies might need 7 or 7.5. Some babies might be okay with 5. Depends on the degree of alveolar dead space again, because these babies do begin to develop some air trapping and overexpansion. But it's important to keep in mind that what we don't see on the ventilator interface is the patient's spontaneous effort. And this is just an example of one set of curves. So this is the standard pressure, flow, and volume curves. I drew in red here the baby's spontaneous effort because it's additive to what the ventilator is doing. The ventilator pushes, the baby pulls air into their lungs. The patient's contribution is variable, sometimes absent. So this is why tidal volume will fluctuate a bit, but we don't see this on the ventilator waveform. But what happens if the tidal volume that we set is less than what the baby wants based on their respiratory drive? We might see this. This baby is not receiving any significant pressure from the ventilator, but yet is generating a big tidal volume, right? And what this scenario shows us, the ventilator is doing exactly what it's programmed to do. When you have tidal volume that's more when the baby generates tidal volume that's more than the set value, the pressure comes down, down, down until the ventilator is generating virtually no pressure. If the baby is tachypnic and retracting, baby needs bigger tidal volume. If the baby is comfortable, then we should probably extubate. And finally, weaning. So weaning occurs automatically. If we set the tidal volume appropriately, lower end of normal, this will occur by itself. Do not lower the tidal volume further unless the pH is alkalotic. Of course, if the pH is above 7.36 or so, the baby may not have a respiratory drive. So we want to make an adjustment. But if you set the tidal volume too low, the baby will again breathe above the set tidal volume, and you'll see that scenario I showed you on the previous slide. And then when the settings are low enough and the baby's comfortable, baby should be able to be extubated. So just to summarize, volume, not pressure, causes lung injury primarily. We have good evidence that volume guarantee reduces serious complications of prematurity. It's important to keep in mind that one size does not fit all. You need to pick the right tidal volume. You need to understand what's going on with the particular pathophysiology of your baby, and then set the other ventilator settings based on that. And you need to know your device. If you don't have a device that has all these full capabilities, doesn't measure tidal volume in the right place, you're going to not be able to follow these guidelines specifically. So that's all I have. Thank you very much. And I believe we have a few minutes for questions. I apologize, I went a little bit over my allotted time. So Thomas, take over.
Thank you very much, Martin, for your presentation. This was very interesting. Even if you have used a little bit more time, so we have just a few minutes remaining for questions, but however, we will start immediately. So please put in your questions, if you haven't done this already, put your questions into the questions section of your tool on the right-hand side of your screen. But we have already 3 questions what I would like to read for you, Martin. The first one, Professor Keszler, do you think that the term volume guarantee is a misnomer or misleading when that then what the servo control does is to track and smooth and modify the volume delivered, but by no means guarantee it?
Well, it's a fair point, and I used to say that regularly. In fact, some of my slides I had the guarantee in quotation marks, because indeed it does fluctuate. It is guaranteed if the patient is paralyzed, you will get exactly what you said. It is the baby's intermittent and variable spontaneous effort that always perturbs the equilibrium, and the tidal volume will fluctuate a bit around the target, but it certainly is much more stable, and it works. But it's a name that's stuck. It's a name that that people have started to apply in a generic way to other modes of volume targeted ventilation. So I'm afraid we're stuck with it, but your point's well taken.
Second question is, hi, when we switch on leak compensation feature, does machine provide leaked amount to the baby as tidal volume, as VT, or the value shows as VT is only a calculated amount, which suggests us that this amount should go to the baby?
So with the leak compensation, the device simply calculates the true tidal volume that entered the patient's lungs. So what you see is what you get, and the important thing is that the pressure is regulated to maintain that correct tidal volume, as opposed to the tidal volume that's misleading and potentially underestimating the real tidal volume. So it doesn't add anything. It simply uses the algorithm to derive an accurate estimate of the true tidal volume that entered the patient's lungs. It's something you always should use, because that is incredibly accurate, and it allows you to ventilate babies with a large leak safely.
Thank you, Martin. There's a second question, which is more or less about the same topic. The question is, what do we look for, VTI or VTE or VT on screen to monitor whether volume delivery is proper or not?
So when you have volume, when you have leak compensation on, you should use the VTE. I'm sorry, the VT, which is the calculated value. The VTE is the actual measured value that is typically significantly underestimating the tidal volume that actually entered the patient's lungs. So you should configure your screen pretty much. I'm just interested in the calculated tidal volume and the tidal volume per kilo, which is again based on the calculated value. So the leak, the device tells you the proportion of leak, so you don't need necessarily to see the inspired tidal volume and the expired tidal volume separately. But it's, everybody has their own preferences, what you look at, but the VT is the derived accurate estimate of tidal volume.
Yeah, thank you. Another question is, can you repeat why smaller babies have a higher tidal volume?
Yeah, a lot of folks are confused by that, and the tendency was, oh, it's a tiny baby, so we want to be gentle, so we use a low tidal volume, and actually that doesn't work. So it is the dead space of the flow sensor, right? So there's always some of the gas that you push into the circuit that never reaches the baby's lungs, right? Because there is some dead space of the large airways, the endotracheal tube, and now you add a flow sensor to it. So when a baby weighs a kilo and has a tidal volume of 5 ml, let's say, the proportion accounted for by the flow sensor may be 0.8 ml, but the baby is half that size. The baby is only 500 grams. That flow sensor is still 0.8 ml, so it's proportionately larger. That dead space takes more of the tidal volume, so less gas, less fresh gas reaches the alveoli, if the baby had alveoli, terminal air exchanging units. And so you have to compensate in order to achieve adequate alveolar ventilation. It's a relatively small degree of compensation, because it turns out that there is some admixture of fresh gas and dead space gas. So it's only about 1 ml per kilo more for the really small baby to compensate for that flow sensor dead space. But tidal volume measurement and regulation are important, and taking out the flow sensor, as some people used to do, is counterproductive. Actually, we did this study to convince people that that's a wrong thing to do.
Thank you, Martin. There's another question. Does the volume guarantee calculation happen breath to breath, or does it get averaged over a few breaths?
It is averaged over a few breaths. Baby's respiratory effort is fairly erratic, so it is averaged over a short period of time. I don't know the exact number. Thomas could tell us, but it's not breath to breath.
Mm-hmm. It's about 8 to 9 breaths. What you need to reach about 90% of your target if you change this. So this is approximately to give you an idea how long this takes. So there's another question about leak compensation. So if leak compensation is on, do the pulmonary graphics change as you had indicated in your slide? The leak is still present, isn't it?
Yes, the leak is still present, and that's one of my pet peeves is the leak. The graphics use the calculated values, so you don't see the leak on the graphics as you would. I would love to have the option of displaying the graphics as they are, because it's well, that's just habit. But but you can see from across the room that the baby has a large leak. So the graphics are modified. You do not see the leak. You have the leak indicated by the % leak, but the graphics look as though there were no leak because it's using the calculated value.
Thank you, Martin. That is an important point everybody needs to know, because otherwise there's a misinterpretation possibly of the leak situation. Yeah. Next question. One common problem is a small newborn that fall into the ET CPAP as you shown during lecture. Residents argue that keeping that is harmful, so they switch off tidal volume or volume guarantee, which on my view is counterproductive. Can you clarify us?
Yes, you are correct. It is counterproductive. So if the baby is, as I showed in that slide, essentially on endotracheal tube CPAP, what this tells us is that the baby is spontaneously generating a larger tidal volume than what is set. So the decision that needs to be made is, does this baby actually need to be intubated and mechanically ventilated? And if so, then the baby needs more support. So it's a clinical assessment, right? Is the baby tachypnic? Is he or she retracting? Is the oxygen requirement rising? If that's the case, then obviously the baby needs more support, so it needs a bigger tidal volume. If the baby, on the other hand, is quite comfortable, the FiO2 is 24%, and the baby is not particularly distressed, we should extubate. But turning off the volume guarantee will simply, it'll fix the problem in a way, but it means that the baby's going to have to work harder. So volume guarantee, some people tell me it didn't work for this baby or that baby. What it really means is we didn't know how to make it work, because it works essentially always. You just need to understand the interaction between the baby and the ventilator, and how what information you can derive from the waveforms and looking at the baby. So in this scenario, it's one of two things. Either the baby really doesn't need to be ventilated anymore, so extubate, or the baby needs more support.
Thank you. There are a number of more questions. I think we have to close in a few minutes. But nevertheless, here's one more. Immediately after surfactant delivery, due to surfactant lying in the bigger airways, it is safe to use volume guarantee, or should we switch on to volume guarantee only after a few minutes? So
that's a controversial issue. There are some obvious advantages for actually using volume guarantee around the time of surfactant administration, because compliance can change fairly rapidly. On the other hand, if there is a complete obstruction of the intratracheal tube with surfactant, as a safety measure, the ventilator will drop the pressure. If it senses complete obstruction, it will not continue to escalate the inflation pressure, because that potentially would be dangerous once the obstruction is relieved. So it's programmed, perhaps the intratracheal tube is kinked or the tubing is kinked, and there's no tidal volume at all. That's not a common scenario, but it's been described. So for that reason, some people say we're not going to use volume guarantee right around the surfactant administration time. On the other hand, we know that surfactant administration does cause some transient small airway obstruction, and you need to generate more pressure to force the surfactant through very transiently. So having the ventilator automatically increase and then rapidly decrease the inflation pressure seems like a good idea. It's a study I've always wanted to do, but never quite got around to doing, comparing using volume guarantee or not using volume guarantee during surfactant administration. Somebody out there, please do it.
Thank you. As a last question, I have here one, which is possibly a little bit of marketing for Dräger. Hi, Dr. Keszler. May I know which ventilator models have the ability to correct the tidal volume to compensate for the leak?
So it's the VN500, 600, and 800 that have that capability. The BabyLog 8000 Plus has leak adaptation, meaning that it takes care of issues of auto triggering and breath termination, but did not have the leak compensation feature, which has made a huge difference. With the BabyLog 8000 Plus, you do not have that availability. With the other ventilator, there are other manufacturers that really don't have this sort of technology, which is really, to me, a real game changer. I don't own any Dräger stock, but it's a device that is superior to others. That's why I use it. That's why I talk about it.
With these words, I would like to close the session for today. Martin, thank you very much. We spoke and discussed with you that we have some more questions, not too many, but there are still some left to answer. And so, Martin, you said that you would spend a little bit more time later today or tomorrow to type in the answers, so we can send around the answers to the remaining questions later within the next days. Thank you very much for logging into our webinar, and thank you, Dr. Keszler, again for conducting this webinar with us. The webinar recording will be available on our website in the next days. You will receive an email from us with a link to our online neonatal ventilation platform, where we offer educational content and where we also inform you about upcoming events like this webinar today. And in fact, we have next week, we have a webinar with Professor Vento about high frequency oscillation. So you can also find this on our webpage. We would be also happy if we receive your feedback for today's webinar. And with these words, I would like to say goodbye and have a nice day. Thank you.